We're at the 26th CROI. We're here with Tony Fauci, who is the director of NIH and has been so gracious as to do these programs with us over the years. And today there's, we hope, a landmark moment, and there's been so many in AIDS, in trying to develop a plan. Your presentations have always been so aspirational, and some have a plan, and this one definitely has a plan. And I'd like you to describe that to us.
Yeah, well, what we have done, we being the Department of Health and Human Services, involving both the CDC, the NIH, the HRSA, Health Services Resources Administration, the Assistant Secretary for Health, and the Indian Health Services, put together a plan based on some fundamental principles that we have the tools, particularly treatment as prevention, where if you treat someone who's infected and drop their viral load to below detectable level, they will not transmit their infection to anyone else. So not only will they save their own lives, but they won't transmit the infection. And the high success that we know now with pre-exposure prophylaxis, even though we don't fully implement it, we know that if a person takes PrEP 1 pill a day, they decrease by at least 95% the likelihood that they'll acquire HIV infection. So if you put those two things together, and theoretically then, if you put everybody who's infected on any retrovirals and give everyone at risk PrEP, theoretically you could end the epidemic tomorrow. But we don't live in a theoretical world, we live in a real world. So how do we make that translation from the idealistic to the reality? And that is if you focus the way we feel we can on both demographic and geographic concentrations and hotspots. Demographically, we know that there's a great disparity with HIV. We know that it actually is very heavily concentrated in certain populations. 13% of the population in the United States is African American, 44% of the infections occur in African Americans. Almost all of them, a very high majority of them, are men who have sex with men. And then we also have a high concentration in young people. So we have young African American and Latino men who have sex with men. The other thing that really tipped us off about how we might do this is that in the United States there's geographic concentrations. We have 3,007 counties in the United States. In 48 of those counties, plus the District of Columbia, plus Puerto Rico, so in 50 places out of 3,007, more than 50% of all the infections are concentrated.
That's an amazing statistic.
That's an amazing statistic. So that really got us to believe that if we concentrated our efforts with new resources and a synergy and collaboration between multiple agencies within the United States Department of Health and Human Services, that we would be able to have the goal, which is aspirational, but I hope that we meet it, and I think that there's a realistic chance that we will, to decrease the new infections, the incidence of new infections, by 75% in 5 years and by 90% in 10 years. If we do that, we will have effectively ended the epidemic as an epidemic, because we have about 38,000 new infections each year. If we can get down to 3,000 or less, we're not going to eradicate, nor are we going to eliminate HIV, but we certainly are going to end it as an epidemic as we know it.
So if you develop this as a Manhattan Project with some fluidity in it,
right, yeah.
You can make the changes as you go that you see. You're working with FIFAR,
right.
So they are going to be having the ability to do
the NIH's role will be to perform the implementation research to determine in real time, because this is a 10-year project, so you determine in real time what best practices are. You know that one size does not fit all. There are going to be missteps. There are going to be failures. But you don't want to give up when that happens. You want to learn from that and make sure the next time around. For example, men who have sex with men are going to have a different situation than transgenders, are going to have a different situation among African Americans versus white, among people who live in cities versus people who live in rural areas, transgenders versus others. So we want to get it right for all of them, and we're going to, in real time, get the information out there about what works and what does not work.
And developing a relationship with the population specifically.
It's critical. It's totally critical that you get down to the grassroots and community level. It's not going to be from above. It's going to be getting into the field, into the trenches. State, community, local, faith-based, all are going to have to be done.
Maybe use some stars or sports figures, I don't know.
Well,
get
we'll
this
see.
going.
We'll see.
It'd be great to have that inspiration
Right.
behind it. Yeah.
Right.
But you're inspiration enough for us. It's just getting it out to the people who
we're
don't
gonna
talk
try.
to you.
We're going to try. We're going to try.
Well, I thank you very much for
Right.
your work, and
My
I look
pleasure.
forward to the presentation this
Right.
evening.
Right. Good to see you. Real pleasure.